I want to tell you about a phone call I received 3 years ago that changed the way I practice medicine. My father was 74 years old. He had driven himself to a routine checkup at his local clinic, the kind of appointment he had been attending without me for years because he was independent, capable, and frankly, a little stubborn about accepting help from his own son. He called me from the parking lot afterward, and the first thing he said was, "They gave me a shot today, something for travel." We didn't really talk about it much. I just rolled up my sleeve. And when he told me which vaccine it was, I felt something drop in my stomach. Because I knew what the research said about that particular vaccine in adults over 60. I knew what the CDC's own data showed about the risk profile. And I knew that my father, who takes medication for a heart condition and has mild kidney disease, was precisely the kind of patient for whom that vaccine was most likely to cause a serious problem. He was fine. We were lucky. But I drove to his house that evening, and I sat across from him at his kitchen table, and I thought, if my own father, the father of a physician, can walk into a clinic and receive a vaccine that carries documented age-related risks without a single informed conversation about those risks, then how many other people's parents are doing exactly the same thing right now? Sitting in waiting rooms, rolling up their sleeves, trusting completely, never asking a question, never being given the information they would need to ask one. My name is Dr. William Madison. I have been practicing medicine for over 2 decades. I am not here to tell you that vaccines are dangerous. I need you to hear that clearly before we go any further, because this conversation deserves precision and not noise. Vaccines are among the most consequential achievements in the history of human medicine. They have prevented more suffering and saved more lives than perhaps any other medical intervention ever developed. I believe that without reservation. But I also believe something that the medical system does not always take the time to explain clearly to patients and families. Not every vaccine is appropriate for every person at every age. And once a person crosses 60, the biology changes in ways that are real, documented, and directly relevant to how specific vaccines behave inside the body. The immune system at 65 is not the immune system at 35. A process called immunosenescence gradually reduces both the speed and the precision of immune response. Organs process substances differently. Underlying health conditions and the medications used to manage them alter how the body reacts to what is introduced into it. These are not excuses to avoid vaccination. They are reasons to choose vaccination intelligently, with full information, and with an understanding that the recommendation appropriate for a 40-year-old is not automatically appropriate for a 75-year-old. Today, I am going to walk you through 5 specific vaccines that I, as both a physician and a son, would not allow my own parents to receive after the age of 60 without an extremely careful, detailed conversation first. Some of these will surprise you. Several are routinely offered to older adults in clinics and pharmacies across the country, presented as standard recommendations, with little or no discussion of the age-related risk profile behind them. By the time you finish watching this, you will know what questions to ask. And those questions could matter more than you realize. The first vaccine I would never let my parents receive after 60 is the live attenuated influenza vaccine, commonly known as FluMist. It is the nasal spray version of the flu vaccine. No needle, no injection. You simply tilt your head back, a nurse sprays it into each nostril, and you walk out feeling like you barely did anything at all. For many people, that simplicity is genuinely appealing. No fear of needles, no sore arm, no sitting in a chair bracing for the stick. But here is what that appealing simplicity conceals. FluMist contains a live virus. Weakened, yes. Attenuated, yes. But biologically alive and active inside your body from the moment of administration. For a young person with a fully functional immune system, that weakened virus is handled efficiently. The immune system recognizes the threat, mounts a response, builds antibodies, and neutralizes the virus before it can cause illness. The whole process is precisely what the vaccine is designed to trigger. For a person over 60, the calculation is different. An aging immune system is slower to recognize a threat and less precise in its response. When a live pathogen, even a weakened one, is introduced into that environment, the outcome becomes less predictable. The immune system may struggle to contain what a younger immune system would neutralize easily. The result can be prolonged flu-like symptoms, respiratory complications, and illness that the person believed they were being protected against. It is worth noting that the FDA does not approve FluMist for anyone over the age of 49, and yet I have heard from patients who received it in their 60s and 70s, offered at pharmacies, administered at walk-in clinics, given without age screening and without the informed conversation that should accompany any live vaccine in an older adult. The alternative is not to skip flu vaccination. Influenza kills tens of thousands of older adults every single year, and annual vaccination remains critically important after 60. The alternatives are the high-dose flu vaccine and the adjuvanted flu vaccine, both of which were specifically developed for aging immune systems. They deliver a stronger, more reliable immune response, without introducing a live virus into a body that may not be equipped to manage one safely. If your parent is over 60 and is offered the nasal spray flu vaccine, ask for the high-dose or adjuvanted injectable version instead. That is what I would do for my own father. The second vaccine on this list is one that many older adults may have already received, and if they did, the timing of when they received it matters significantly. I am talking about the older shingles vaccine known as Zostavax. Zostavax was for many years the only shingles vaccine available. Doctors prescribed it because it was the only tool they had, and it was genuinely better than leaving older patients completely unprotected against a disease that can be agonizing and permanently disabling. Shingles is not simply an uncomfortable rash. It can trigger a complication called postherpetic neuralgia, nerve pain so severe and so persistent that it continues for months or years after the visible rash has healed. It can damage vision. In older adults with compromised immune systems, it can become a systemic crisis. So the intention behind Zostavax was sound. The problem was the vaccine itself. Zostavax was a live vaccine. It contained a live attenuated form of the varicella zoster virus, the same virus responsible for chickenpox that lies dormant in nerve tissue for decades and can reactivate as shingles. And its performance in the population that needed it most was deeply disappointing. Research showed that efficacy in adults over 70 was around 18%. In adults over 80, it was even lower. A vaccine with that efficacy profile, combined with the inherent risks of a live virus in an aging immune system, including documented cases of shingles-like illness and complications following administration, is not a vaccine I would stand behind for my own parents. The good news is that Zostavax has been discontinued in the United States and replaced by Shingrix, a recombinant non-live vaccine with a completely different mechanism and a dramatically better efficacy profile. Shingrix demonstrates over 90% effectiveness even in adults over 70. It does not contain a live virus. The immune response it generates is more robust, more durable, and far more appropriate for an aging immune system. If your parent has not yet received any shingles vaccine, make sure they receive Shingrix. If they received Zostavax years ago, talk to their physician about getting Shingrix now, because the protection from Zostavax fades substantially over time and was likely insufficient from the beginning in adults over 70. This is a conversation worth having at the next appointment. The third vaccine is one that comes up not in routine care but in the context of travel, and it is one of the most important conversations I believe older adults and their families are not having. The yellow fever vaccine. Retirement travel is more common than it has ever been. Adults in their 60s, 70s, and even 80s are pursuing the journeys they deferred for decades. South America, Sub-Saharan Africa, parts of Southeast Asia. And many of these destinations require proof of yellow fever vaccination for entry, or travel medicine providers strongly recommend it before departure. So a 70-year-old decides to visit Brazil or Kenya, walks into a travel clinic, and is told the vaccine is required. They roll up their sleeve without further discussion, because the word required does not leave much room for hesitation. Here is what that conversation should include but often does not. The yellow fever vaccine is one of the most effective vaccines ever created. It is also a live vaccine, and it carries one of the highest serious adverse event risk profiles of any vaccine currently administered. The CDC explicitly acknowledges that adults over 60 face a significantly elevated risk of severe complications from yellow fever vaccination. There is a condition called yellow fever vaccine-associated viscerotropic disease, in which the live vaccine virus overwhelms the body's defenses and causes a systemic infection that mimics actual yellow fever, damaging the liver, kidneys, and cardiovascular system simultaneously. The mortality rate for this condition is extraordinarily high. Most people who develop it do not survive. This is rare. I want to be precise about that. The majority of older adults who receive this vaccine do not develop this complication, but the risk rises substantially with age and rises further in the presence of underlying health conditions, which the majority of adults over 60 have. When you are evaluating whether to administer a live vaccine with a potentially fatal rare complication to a 72-year-old with hypertension and mild diabetes, The calculus looks very different from the same decision applied to a 30-year-old with no health history. If travel to a yellow fever endemic area is genuinely important to your parent, a serious, specific conversation with their physician is not optional. In some cases, a medical waiver can be obtained. In some cases, the risk-benefit analysis simply does not support vaccination, and the trip needs to be reconsidered or redirected. I would rather my father change his travel plans than receive a vaccine with a documented and age-amplified risk of a fatal outcome. The fourth vaccine on this list follows the same pattern you have likely begun to notice, and it is worth naming that pattern explicitly before we continue. The common thread is live vaccines in older adults. The oral typhoid vaccine, sold under the brand name Vivotif, is a live attenuated vaccine administered in capsule form, typically given to travelers visiting parts of South Asia, Africa, and Central or South America, where typhoid fever is endemic. There is also an injectable typhoid vaccine that uses an inactivated form of the bacterium. The two products offer broadly similar protection, but for an older adult, they are not interchangeable in terms of safety. The oral typhoid vaccine contains a live strain of Salmonella typhi. In a person over 60 who is managing chronic health conditions and taking multiple medications, many of which are common in that age group, including immunosuppressants for autoimmune conditions, corticosteroids, or medications for diabetes and heart disease, introducing a live bacterium into the digestive system carries risks that are meaningfully greater than in a younger, healthier person. Gastrointestinal side effects are more pronounced, drug interactions are more likely, and the long-term efficacy data in older populations is less robust than advocates of the oral vaccine sometimes acknowledge. The injectable typhoid vaccine avoids all of these concerns. It uses an inactivated antigen. It does not carry the same drug interaction risks. It is the option I would choose for my own parents without hesitation. If a travel medicine provider recommends typhoid vaccination for your parent, ask specifically for the injectable form, not the oral capsules. It is a simple and direct request, and any good travel medicine provider will accommodate it without resistance. The fifth and final vaccine on this list requires the most careful and nuanced discussion of all five, because it is the least commonly encountered, but carries some of the most serious potential consequences for older adults who receive it inappropriately. The BCG vaccine, which stands for Bacillus calmette-guerin, is primarily used for protection against tuberculosis. In the United States and most Western countries, BCG is not part of the routine vaccination schedule, and most people will never encounter it in a standard clinical setting. But there are circumstances in which an older adult might be offered or recommended BCG. Extended travel to countries with high tuberculosis burden, participation in certain clinical research settings, and there is an emerging body of research exploring BCG's potential effects on immune function in older adults, which has generated some clinical and academic interest in broader applications. The concern is this: BCG is a live vaccine. It uses a live attenuated strain of Mycobacterium bovis, a close relative of the bacterium that causes tuberculosis. In young, healthy individuals with fully functioning immune systems, BCG vaccination is well tolerated. The live bacterium is contained efficiently, and the immune response it generates provides the intended protection. In an older adult with diminished immune function, and particularly in any adult of any age who is taking medications that suppress immune activity, the scenario is different. There are documented cases of disseminated BCG infection, a serious complication in which the live vaccine bacterium escapes immune containment and spreads to multiple organ systems. Symptoms include persistent fever, significant weight loss, and infections in locations remote from the injection site. Treatment requires prolonged courses of anti-tuberculosis medications, which carry their own significant risks for aging kidneys and livers. This is a complication that occurs rarely in the broader population, but becomes a meaningful clinical concern when the patient is over 60, immunocompromised, or both. For virtually every situation I can imagine involving my own parents, I would find another approach to tuberculosis risk management before I would recommend BCG vaccination after 60. I want to step back from the specific vaccines for a moment and tell you something about why this conversation matters to me beyond the clinical details. Medicine has two failure modes that I have watched cause real harm to real patients throughout my career. The first is the failure of undertreatment, when people who need medical intervention do not receive it because of fear, misinformation, or lack of access. The second is the failure of overtreatment, when medical interventions are applied without adequate consideration of whether the specific patient in front of you is the right person to receive them. Both failures cause suffering, and older adults are disproportionately vulnerable to the second type, because the medical system often operates on population-level guidelines that were developed with younger or healthier populations in mind, and then applied uniformly across all ages, without the individualization that genuinely good medicine requires. What I am asking you to do is not to distrust medicine. What I am asking you to do is to participate in it actively on behalf of the people you love. Go with your parent to their appointments when you can. When a vaccine is recommended, ask which specific product is being administered. Ask whether it contains a live virus or bacterium. Ask what the specific risks are for someone of their age and health status. Ask whether there are alternative formulations that carry a better safety profile for older adults. These are not difficult questions. They are not antagonistic questions. A physician who is offended by them is not the physician you want managing your parents' care. A physician who welcomes them is showing you exactly the kind of engaged, individualized practice that older patients deserve. To be completely clear about what I do enthusiastically recommend for adults over 60. The high-dose or adjuvanted flu vaccine every year. The Shingrix shingles vaccine for anyone who has not yet received it. The pneumococcal vaccines for protection against pneumonia and related infections. Updated COVID vaccines for older and higher-risk adults, and the Tdap booster for tetanus, diphtheria, and pertussis. These vaccines use inactivated or recombinant technology. They have strong safety records in older populations. They protect against diseases that disproportionately kill older people. I would encourage every adult over 60 to make sure they are current on all of them. The message of this video is not to avoid vaccines. It is to choose them with the same care and individual consideration that every other medical decision in your parents' life deserves. My parents mean everything to me. Every medical conversation I have had with my father at his kitchen table, every question my mother has called me to ask from a waiting room, I treat with the same weight I would give any patient whose life I feel genuinely responsible for. Because I am. And because you are too. For the people in your life who trust you to help them navigate a medical system that does not always slow down long enough to ask the right questions on their behalf. If this gave you something useful, share it with someone who needs it. A sibling, a friend with aging parents, someone who has a parent going in for an appointment this week who does not yet know which questions to ask. I'm Dr. William Madison. Take care of yourself, take care of the people you love, and I will see you in the next video.